Hello, I'm Michelle Lavander, Director of the USC Center for Health Journalism. Thanks for joining us today and welcome to our Health Matters webinar, Get the Story on the Coronavirus Crisis. This global story is moving so fast that it's hard to keep up. The preoccupation of the moment is the stock market and jitters about a global recession. Yesterday, we focused on the Trump administration's official response, and in recent days, we've also heard about the emergence of more cases in Iran, South Korea, and other places around the globe. While China remains the epicenter of the outbreak, the World Health Organization has said countries should prepare for a possible global pandemic. Today, our experts will help you get a handle on this complex and multifaceted story. We'll start with some fundamentals that will help you respond to each day's new developments. You'll also hear the latest on what scientists know and what they are still struggling to understand. And we'll discuss how public health officials and journalists can respond to a wave of xenophobia and racist attitudes toward Asians and Asian Americans. Our three distinguished speakers will help us understand and calibrate reporting on this emerging public health threat. We are honored to have joining us here today Dr. Michael Mina, MD, PhD, and Assistant Professor of Epidemiology at Harvard's T.H. Chan School of Public Health, and a core member of the Center for Communicable Disease Dynamics. Dr. Mina's research combines mathematical and epidemiological models with serum-based laboratory investigations to better understand the consequences and patterns underlying infectious diseases. Emily Baumgartner is a medical reporter for the Los Angeles Times, focused on investigations and features. She joined the Los Angeles Times newsroom in 2019 from the New York Times Washington Bureau. She has reported on the Ebola epidemic in West Africa and the 2016 yellow fever outbreak in the Democratic Republic of the Congo as a Pulitzer Center on Crisis Reporting grantee. And we're also going to hear from Dr. Seema Yasmin, a journalist, author, medical doctor, and professor. Dr. Yasmin served as an officer in the Epidemic Intelligence Service at the U.S. Centers for Disease Control and Prevention. She was a finalist for the Pulitzer Prize in Breaking News in 2017 with a team from the Dallas Morning News, and recipient of an Emmy for her reporting on neglected diseases as a USC Center for Health Journalism Fellow. In 2017, Dr. Yasmin was a John S. Knight Fellow in Journalism at Stanford University, investigating the spread of health misinformation during epidemics. She has served as a science correspondent at the Dallas Morning News and medical analyst for CNN. She teaches science journalism and global health storytelling at Stanford University. This webinar is offered thanks to the generous support of the Commonwealth Fund and the National Institute for Healthcare Management Foundation. You can tweet about the webinar at the hashtag coronavirus. A word about our format today. We'll be hearing from our panelists first, and then we'll turn it over to our audience for questions. Because we have several hundred people on the call, we'll ask you to write your questions into the control panel of GoToWebinar. You can write us there if you're experiencing technical problems as well. We'll be archiving this webinar at centerforhealthjournalism.org. Now, let's turn to our speakers. Dr. Mina, let's start with you.
Hello, my name is Michael Mina, and I'm kicking off this webinar for the three of us to give an introduction to what we know about this novel coronavirus known as SARS-CoV-2 thus far. And so this will be quite distinct from some of the next couple of presenters. And this will go through some of the more basic biology, a little bit of how we know when this virus has emerged, and I will focus at the end on some of the testing capacity that we have, and this has been something that's been in the news quite a bit lately. So just because you can't see me, this is who I am. I'm an assistant professor of epidemiology and an assistant professor of immunology and infectious diseases at the Harvard School of Public Health. And I'm also the associate medical director, and specifically I head up some of the molecular virology diagnostics, including Brigham and Women's Hospital, which is a Harvard teaching hospital's approach to diagnosing and dealing with this coronavirus. So to give a bit of background here, the virus emerged in Wuhan, which is in the Hubei province of China. That was on December 8th. It was first detected in the Wuhan seafood market and linked to that market, and it's assumed to have arrived via some zoonotic transmission and a transmission event from an animal to a human in the market. But when exactly, what exact animal it emerged from and jumped into humans from is not quite known at this point, although there's been a lot of speculation and a lot of work trying to determine where it came from. And I want to show this graph here, this bar graph that you can see, to point out that the response to this within China and the global community has been truly astounding. And what you can see is that although the virus was first detected December 8th, by just over a month and a half after that, we already had a full genome sequence for the virus within a month, and then the China CDC had actually been able to put out testing kits and start actually testing for people using molecular tools, all within a 45-day period or so. And that's just an astounding time frame for these types of epidemics. And I'll talk a little bit about more how all of that came about. But what you can see in the dark orange of this graph is that there was a low level of cases that were early on linked to the seafood market, but very quickly in the lighter orange bars, you can see that the epidemic sort of took off from the Wuhan market, and those indicate cases that were not directly linked back to the market. So the spread was pretty rapid of this virus, which I think we're all aware of at this point. We can actually use lots of different tools now to understand when this virus was able to jump into humans. And so in this case, what I'm showing is on the left side, we can see that that's just a list of different sequences of different isolates that have been performed for various viruses that were detected from people. And we can look at how many mutations each isolate differs from the next. And we can actually start building trees. The numbers of mutations, viruses mutate on a regular basis normally. And how they mutate and how many mutations they are from each other actually gives a little bit of a clock. And it's because they mutate sort of in a regular pace. It doesn't mean anything they're not necessarily mutating to become worse or better. It's just normal variation. And we can actually use these types of genetic tools to actually infer back the time since when this probably jumped into humans. And I apologize that there's a sentence covering this, but essentially the estimated date of the most recent common ancestor, which is the MRCA, or this is essentially the date that this likely jumped into humans, can be calculated from the genetic code back to about November 29th, and potentially back to October 30th, just depending on the assumptions that are made in the model. But this is to say that we have a very good idea that all of these cases probably originated sometime in October, November, given a jump from an animal into a human. And we now have very sophisticated tools to be able to assess this without actually having to discover the first animal where it jumped from. So to put this in a little bit of context, this virus, which is in humans, is actually very closely related to a number of other viruses, a number of other coronaviruses. And so you can see this is a phylogenetic tree, or sort of a map of how closely resembling different viruses are. And this shows a number of isolates in the red box here, which represent this novel coronavirus, the SARS-CoV-2. And what you can see is it's surrounded by, its nearest neighbors are bat coronaviruses. And so we believe that this likely originated from a bat at some level, maybe had an intermediate host, and jumped into humans from there. And what you can see is also up here is SARS. That was from about 15 or 16 years ago. SARS was one virus that jumped into humans and infected thousands and killed quite a lot of people. And then we also have seasonal coronaviruses, which are very normal viruses, and they're the viruses that cause the common cold, and they're also closely related, and they're represented at the bottom of this chart. And so there's a lot of different coronaviruses, and this fits into what we would essentially what we could expect, what might be another virus that would have jumped into humans. And I point that out because there's been a lot of speculation of whether this was sort of a virus that was developed in a lab, and the closeness of it to other strains that we know of is very good evidence that there's no nefarious activity. This is really just an unfortunate event of jumping into humans. So after the virus was initiated in Wuhan in the seafood market, it grew very rapidly. And this graph is just to show just how swift the transmission out of Wuhan was. And so on the top, that's a graph showing the Wuhan cases. And almost within about a week or so, we started also detecting specimens outside of Wuhan in other areas of the same province in China. And then a little bit later after that, we can see that the chart starts to build up, and we start to see incidents of cases being detected in early January that are it really starts to pick up in the rest of China. And overall, you can see this very significant exponential curve, which we expect for a virus such as this, where each case is leading to multiple additional cases. In the case of this virus, it generally tends to lead to 2 to 3 additional cases for every one that occurs. So currently, as has been all over the media, we know that this is sort of transitioning, and at this moment in time, I don't believe that that the CDC or the WHO have yet used the word pandemic to describe this virus, but I think most epidemiologists around the world, including myself and my colleagues, definitely consider this at this point to be sort of the definition of a pandemic. And that's because it's spreading now locally in many countries, not just China anymore. And at least as of this morning, it's been detected in at least 57 countries based on some CDC data. And with over 80,000 confirmed cases. It's also important to note that those confirmed cases probably represent somewhat of a very low estimate of the true numbers of cases that are occurring globally. Many of those have occurred in China, but now we're recognizing that more and more cases are popping up wherever we start introducing testing. And it could be that actually the total number of cases is well over 1 million at this point. It wouldn't be a stretch to assume that the number is actually 10 times higher. So the coronavirus is made of, it's made of a single genome, and I don't want to go into detail, but the reason I want to point out some of these features is because there's been a lot of questions about what the tests are looking for. And so there's sort of the virus has one long strand of RNA that it's made out of, and that's a piece of genetic code. And then it actually chops up that RNA into little bits and each of those little bits makes a different protein that forms a part of the housing of the virus, or the capsule of the virus. And so, for example, we've heard about the spike protein recently in the news, and that's displayed on these yellow bits, and these are the pieces that bind to people's cells and allow infection. And I just want to point out the N protein, or the nucleocapsid, is what the PCR assays, the tests that CDC has produced, is actually looking for this little bit of genetic code that we refer to as N, or nucleocapsid. And it's actually a piece of genetic code that forms a structure, a piece of the virus. So to put this in a little bit more context, there's a lot of questions about, well, just how bad is this virus, and how transmissible is it? And this virus would certainly sit in the category of being moderately transmissible and moderately severe. So in terms of transmissibility, you can see here on the x-axis, we have severity, we have transmissibility, and measles is way out here all the way to the right. And that means for every case of measles, you get about 15 new additional cases. So measles is extremely transmissible. This new virus, the SARS-CoV-2, sits more between 2 and 3. And so that makes it just a moderate transmissibility, but it's also moderate severity. And so it's not Ebola, it's not SARS or MERS in terms of killing 10 or 15 or 50% of people like Ebola. But it does seem to be killing around 1 to 2% of people. So that puts it in a moderate transmissibility and moderate severity. And in my opinion, a virus that is both moderate in both of those is really a virus that we should be very, very concerned about at a global level, because that means even though it's not the most severe infection in terms of how many people it kills, the fact that it can also spread widely like we're seeing makes it a very dangerous virus that I think the world is coming to terms with at this moment in time. So in terms of the severity and just who's getting infected, on the left here, this is some data that came from Wuhan early on. And essentially what this is showing is that the majority of people who are getting infected fall between the ages of 30 and 80. And with lower numbers of people in the 80s and 90s, only because there's fewer of those people. But we can see the average age of infection is somewhere in that range. And what's very notable here is that very, very few children are actually becoming infected with this and reported to have this illness. And if we actually look at who's then dying, what we see is that there's this very clear and striking pattern where there's almost no death and very, very, very little severe disease in young children. But that scales up in these red bars. It scales up to those who are over 80. There's around a 15% mortality rate if you are diagnosed with this virus and you're over 80. 15% of those people have passed away because of it, and it's highly linked to other comorbidities. So the vast majority of people who are dying from this also have cardiovascular disease and diabetes in particular, and those end up increasing the mortality rate overall quite a bit. So this seems to be a peculiar virus, and that usually we would expect more of a U shape, where we would also see younger children also being reported to have the disease and dying. But in this case, it seems that younger children are spared. So testing has been in the news a lot. And just to give a very, very brief primer on this, testing is done by a molecular process called real-time PCR. And this is where we actually have little bits. We have these little molecular tools that can go and seek out a little piece of the viral genome, and it can tell us if that virus actually exists in a person's, in this case, a swab that's taken from the back of the throat or the nose. And there's two main tests being used in the world right now. The WHO endorses what's often referred to as the Drosten protocol. It was developed in Berlin by Christian Drosten, and it targets 3 different genes in the genome. And that's important because it differs from the US test, which came out and targets 1 gene, but targets 3 different parts of that. And we've all heard that there was some blunders with the CDC test kit. They were initially sent out in February, on February 6th, and there was essentially 1 kit was sent out to each state lab. Each of those had around 700 tests per kit, so it wasn't a lot of testing that was really available at the time. But ultimately, because each state had about 700 or 800 tests available to it, and ultimately what we saw was that there was a problem with the assay, and many of those test kits actually ended up being recalled. And it seems to be that one of those 3 targets on the N protein wasn't working properly, but it limited the U.S. capacity to be able to deal with monitoring this outbreak pretty severely over the last few weeks since the test kits were recalled. And so these have so far really done significant damage, in my opinion, to hampering the U.S. efforts for detection and really preempting control. of this virus as it continues to spread. Um, to date, there have only been hundreds or potentially very, very low thousands of tests that have been run using this test kit, and so so the U.S. is really lagging behind, I think, in being able to um, to observe where these cases are occurring. And a lot of that was due to this declaration of a public health emergency that, while trying to enforce sort of more capable labs to be the ones that are sort of CDC vetted labs, those state labs to be the ones who are reporting on positive and negative tests, what it also did was it served to really restrict what labs and hospitals could actually do. And at this point in time, regular hospital labs that would normally be looking for things like influenza and RSV in their patients really can't test. And for their patients, if there's a suspicion, they have to send the test out to the states or the CDC, and those can take 2 to 3 days to come back. So it's leading to this very low test capacity in the US, which is becoming increasingly problematic if we cannot get our testing capacity up. And this is particularly the case given that U.S. local transmission has become much more likely, and there's more or less no good way to see that transmission will not occur across the states. So I just mentioned the CDC protocol today. This is sort of a real-time PCR instrument, which is a very common technique we're normally doing in the labs. And so technically, many labs across the U.S. could get this up and running, and we could get testing rolled out in much higher capacity if the FDA and CDC sort of rolled back some of their restrictions currently and allowed the labs in different hospitals to be able to perform what are known as lab developed tests. But looking towards the near future, there's a number of, these are the big players here, these 4 companies are each trying hard to get tests out, and these will be very simple to use clinical tests that can be run in any hospital. And they're all working on getting these out, and probably they'll start rolling out in the US in mid-May. The QIAGEN test, which you see on the top right there, has actually started shipping to Europe and some of the rest of the world. The US has tighter regulations on getting these tests out, and so we always are a little bit slower than in getting tests introduced into the US versus Europe, for example. But once these tests are online, we should see much more capacity to actually be testing for this virus, but that might not be until mid-May or so. And then just one more slide looking way into the future, well, way into the future, relatively speaking, we're going to see really advanced technologies like CRISPR-based diagnostics are going to be popping up very soon. There's been new collaborations between companies to bring this tool called CRISPR, which is a super sophisticated molecular tool for rapid diagnostics. They'll end up looking like pregnancy tests, for example. So these types of diagnostics are really on the horizon, and I think should be the test should be ongoing, and we'll probably start seeing them available, I think, within later this year. And so this is something to keep an eye on in terms of really being able to monitor. And just to finish up, I think that it's very likely that this virus is going to continue spreading, and I think most epidemiologists really believe this. And the US should really continue preparations, working under the assumption that local spread is going to continue. And hopefully testing, as we've all been seeing, is really needed. So that's what I have for now.
Thank you so much, Dr. Mena. Now we're going to hear from Dr. Seema Yasmin.
Hello, everyone, and thank you so much to Michelle's team and the Center for Health Journalism for offering this webinar. I'm going to be talking about press coverage of this situation, some of the challenges, and some of the best practices. I'll be talking about uncertainty, as well as looking at how reporters can work with good sources, looking at innovative story ideas, how reporters can stay safe, and what we can do even beyond the situation, so after the outbreak. Ryan, I'm having trouble advancing my slides, just to let you know. I want to start off just quickly mentioning my background so that everyone listening understand what lens I'm looking at this through. I'm trained in internal medicine and epidemiology and served as an officer in the Epidemic Intelligence Service at the CDC. So I was trained to be deployed into the epicenter of an epidemic, and my job then was to try and figure out what was going on, what was spreading, and how we could try and stop it. I then, based on what I'd seen, decided it was really important to look at how public health crises and epidemics are reported in the press, and I wanted to know how to do that as an expert. So I went to journalism school, trained as a journalist, and then worked as a staff writer at the Dallas Morning News, where it just so happened that when I arrived in the newsroom is when Ebola arrived in Dallas, and I'll talk a bit about lessons learned. I've also been a medical analyst for CNN and done a lot of freelance writing for a number of different outlets. All of that is what brought me to Stanford, initially as a John F. Knight Journalism Fellow, where I got a year out of the newsroom to really dig deep and study how press coverage occurs around epidemics and also the problem of fake health news and the implications of that. I'm hoping we can get my slides going. I do also want to just alert you to a report published in 2015, which is worth looking up. It's called Ethics and Ebola, and it was published by the Presidential Commission on Bioethics. And it includes testimony from me and a section about what we learned from how we covered Ebola, including how initially there was almost very little coverage of the epidemic and very few outlets were doing their due diligence. And then suddenly there was mass reporting and mistakes were made. There was some helpful stuff too. But I do think that it's really useful, even in the middle of this investigation, in the middle of this situation, to look back at what we've learned from that situation. So next slide, please. I want to start by talking about uncertainty because it can be a real point of frustration. And although this feels like very different to other breaking news situations, I really want to address the similarities because in many ways what's happening, yes, it's a health and science story, but it's very similar to any breaking news situation. So for example, a couple of years ago when I was at the Dallas Morning News, we had a mass shooting happen actually very close to the newsroom. There were civilians and police who were shot and police who were shot dead. And as we were reporting, it was mayhem. Everything was changing. And we were trying really hard at the Dallas Morning News to be correct, even if that meant that we weren't always first to publish. But even with that philosophy, we made mistakes. Because, for example, we would get information from the local police department who would tell us X number of our police officers have been killed. We'd publish that, and then the police would come back and say, no, we got that number wrong. It's fewer than what we just told you. And I think many reporters, even if you're not familiar with covering an epidemic situation like this one, you do know what it's like to be in the middle of a fray of just your any other breaking news situation. And so I want us to remember the lessons we've learned there about really vetting sources, really thinking about where our information is coming from, being transparent with our audiences, like, hey, readers and listeners, we're trying to get you the most up-to-date information, but some of this information might change. And we've already seen that happen in just the first few weeks of this situation, because it looked like the numbers have gone up and down, and in some instances, almost like they were going down, when maybe they possibly weren't. And that is because the case definitions changed. And actually, as frustrating and confusing as that can be, it's very normal in the course of an outbreak for case definitions to change. So initially, when you helicopter into an epidemic, you may have no idea of what's going on or what disease is spreading. And you need to have some kind of case definition that you can just communicate with the public and with health departments and healthcare providers. And so you may come up with a case definition that's as vague as people who have fever and a rash between January 1, January 10 in Tucson, Arizona. I'm making this up, right? And you just have to be able to share that, disseminate that. And then as you gather more information and as you gather more facts, you then start to add more color and more detail to that. And then you'll see we normally split it into three. So we have case definitions for confirmed cases, then for suspected cases, and then for probable cases. And again, because those definitions can shift and change, it looks like the numbers are changing in ways that I think do perplex the public. And it's really important that as reporters and editors, we're adding that context and adding that background information that this is to be expected and this is why we think the numbers are shifting. And because, again, it's a breaking news situation, we have to be prepared for numbers and statements that we publish, even though we try to be really careful and we fact check, they could still be changed and they could even be retracted. Michael talked a little bit about mathematical models. I'm going to talk a little bit in a second about how we saw that pan out with the Ebola epidemic of 2014 to 2016. But I just want to make the point that mathematical models use assumptions to create projections. And so when you are reporting on a mathematical model, it's really important when you interview the person, the modeler, to ask, well, what assumptions have you baked into this model? For example, we saw with the Ebola epidemic, like really big projections of there might be 1.4 million people infected by January of 2014, I think it was. But when you talk to those modelers, it turns out they were putting in assumptions to build a worst case scenario. And when I interviewed them after the fact, many months after that had made headlines about, oh my gosh, we could have more than 1 million infections so soon, the modelers admitted, well, yeah, we built the worst case scenario because we wanted to wake up politicians and officials to say, hey, this is what will happen if you don't do anything right now. On the other hand, they built models that we didn't see so much of, where they built in assumptions of, well, if we develop a vaccine by this point, or if we're really good at contact tracing and isolating people. And in those cases, their projections looked much more manageable and less scary than those 1.4 million figures that we were seeing. Next slide, please. So this is what I was talking about. You may remember these headlines about Ebola could infect 1.4 million people in Liberia. And again, it did what the modelers wanted it to do. This generated headlines. This got people talking. You could argue that was useful because maybe there was complacency. There was a lack of due diligence because this was happening to Black people in West Africa. And so people in the West weren't paying attention. Next slide, please. But when I did report, many months after that, it was almost a year after when we kind of saw what had panned out, it turns out that what we'd really actually witnessed on the ground was far fewer infections than what the disease modelers had predicted. And again, they talked to me a little bit about some of their almost political motivations about just wanting people to really care. Next slide, please. We'll be covering so many numbers as reporters looking at this story, looking at how things pan out. And it's important all the time to think about any number that you're publishing encompasses uncertainty. And I want us to start thinking like epidemiologists who, whenever epidemiologists are presented with numbers, we have 16 questions about that number before we're willing to accept anything. And even once we've accepted it, we're still always questioning. And even with what Michael said about, well, we normally would envision a U-shaped chart, and we'd think about, well, how come older adults are being affected with this epidemic and younger kids are? And there's still questions about, well, are we just missing that in younger kids? Like, is that really a true fact? So it's important to talk about that uncertainty, provide context for the calculations, and also bear in mind that things like the case fatality rate, which is that death rate of the virus, it's not a fixed number that's inherent to the virus. It varies so widely depending on which country you're looking at, depending on which month, which part of the epidemic we're in. It's like how the case fatality rate for Ebola was really, really high. And when I was in med school, we were just taught that it was really high and that was almost accepted as fact. And then you saw, well, actually, the death rate of Ebola for white Americans who were able to be airlifted out of West Africa, taken to state-of-the-art centers in Nebraska, for example, was way lower than the case fatality rate we were seeing on the ground in West Africa. So that case fatality rate for Ebola varies so much depending on which country a person is treated in. Next slide. I want us to stick with uncertainty. I know we want to inform our readers, we want to have credibility as reporters and editors, but we can't get away from that uncertainty. There are just too many unknowns at any given time. I want us to stay with the uncertainty and realize that uncertainty is the story. So just before we joined this webinar, I was listening to a BBC radio program with listeners' feedback on how the BBC is covering this current epidemic. And understandably, people are frustrated. The public is like, well, you had one expert on yesterday saying this one thing, and then the same person, the same expert the next day had changed their mind. And that is perplexing and it is frustrating, but it's unfortunately just a factor of situations like this. We're always responding to moving numbers and shifting targets, so we have to be just clear that uncertainty is part of the story. Next slide. I want to talk a bit about vetting sources. In the ideal world, you, the reporter who is sent to report on this epidemic, you are already a reporter who covers health and science, maybe even epidemics are your beat. Ideally, you have deep sources who you've previously vetted and you have long and established and trustworthy relationships with them. Next slide. But let's be real. In real life, this is a breaking news story. You're probably not a health and science reporter being asked to cover this. You're probably just a general assignment reporter who's been told, hey, this terrible thing is happening. We need you to cover this. And epidemics are so much more than health and science stories. They encompass all parts of life. It's why I went into studying epidemics and being a disease detective, because that's what's fascinating about this. Epidemics are city hall stories, they're transport stories, they're pop stories. When Ebola arrived in Dallas, our entire newsroom of a few hundred reporters and editors mobilized, and everybody was covering Ebola. The transportation reporter was covering how some of our metro stations were being shut down because somebody had spit and people were worried about Ebola transmission. So these are very wide-ranging stories, and I want us to be thinking about those larger cultural and societal impacts. Next slide. Because this might not be your beat, and because you may not have trusted sources, it's still really important to think about how you can vet sources on the fly. So right now, unfortunately, you'll be hearing some of the loudest voices, not necessarily the most experienced or the most expert ones. I won't go into details, but there have already been 2 Atlantic magazine articles about one particular epidemiologist who doesn't really have expertise on this, but was fear-mongering on social media and then kind of became a go-to person for a lot of journalists because this person was talking in sound bites and they were saying things that were sensationalized and headline-worthy, but often were not substantiated by the evidence. If you even have just a couple of trusted sources in some fields of science, you can ask them to make some recommendations. And as you're talking to experts, I always trust those people who back out of commenting on every aspect of the situation. Science is really siloed in many ways, so you'll talk to scientists who are experts on like one protein element of the spike protein of the coronavirus. And it can be really frustrating because they're like, no, I'm only willing to talk about this one protein and you want to talk about something a bit larger. But I like those sources because they stay talking about the things that they feel comfortable and knowledgeable about. It's really important to think about diversity in sources. If all your scientist sources are in the US and Europe, then you need to ask yourself, why is that? And what stories and perspectives are you missing with such a narrow range of sources? We've also seen, unfortunately, some scientific sources in the news now who many in the field know that those people are alleged of sexual harassment and ruining the careers of women scientists. You might think, well, who cares about that now? This is an emergency. But the people who know that about them, that damages your credibility and the trustworthiness of your story. So we do have to think about those impacts. Next slide. I have some examples of innovative stories that I want to share with you, some best practices from an amazing science writer. But we're really looking here to offer our viewers and our readers context and perspective outside of what most reporters are covering. Ideally, you want to report from the epicenter, right? But that's not always possible, not always necessary either. And there are some innovative ways of just working really hard though, but to develop sources who are on the ground and who you can pass your microphone to make sure we're hearing voices from people really affected. And again, epidemic stories are more than just health and science stories. They are stories about human rights and poverty, race, politics, and culture. Next slide. So when reporting on epidemics, we want to talk about race because race is a big part of this, and epidemics shine a light on existing injustices. So this always comes up. Next slide. But we don't want to be racist while we're doing this, and unfortunately, we have many examples of how this has happened in the past. Next slide. You may remember this Newsweek cover from a few years ago during Ebola, and we could do a whole talk on just how not only offensive, but how inaccurate and harmful this was. Next slide. We had some great anthropologists and scientists, next slide, respond to just what was wrong with this, and even talking about how damaging and inaccurate that bushmeat term is and the connotations associated with that. Next slide. We saw this reporting more recently, about a year ago, about the current Ebola epidemic in the DRC, which contained inaccuracies. Next slide. But what's useful now is I think we do have platforms where this is a response to that initial article, and it's really helpful that we can have experts weigh in and say, hey, you may have read this particular reporting, it was harmful, and here's what was inaccurate about it. I do worry, though, that how many eyes will land on this countering to the initial inaccurate, harmful reporting. Next slide. We also want to be really careful early on in not naming the virus ourselves as reporters. Next slide, please. So some people were calling this the Asian flu or the Wuhan virus early on before scientists named it, and we can't do that. It's so, the naming of a virus is so impactful and can be damaging and has to be really thoughtfully done, which is why we have these best practices for naming new human infectious diseases. Next slide, which talks about not adding a geography to the place. For example, we saw with swine flu a few years ago that the World Health Organization had to say, oops, we shouldn't have called it swine flu, we're going to go back to calling it H1N1, because people were like, oh my gosh, swine flu, we better kill all of the pigs. And Egypt culled, I think, like a few 100,000 pigs unnecessarily. So the naming of things has a real impact, and we have to be very careful about that, but make sure that we're not giving it a name when it hasn't been officially named. Next slide. And the next slide. So here's just some of the stuff that you can look at later, but it's about how do you name a thing without causing harmful consequences for animals and for people of certain cultures and geographies. Next slide. So I want to talk a bit about racism and epidemics, because we saw this with SARS when it arrived into Toronto in 2003. It was dubbed the Asian flu very unhelpfully and very ignorantly, and I worry that it's not just that this is offensive and xenophobic and there's xenophobia happening, but it gives people this sense of security that if you're not Asian or if you're not around Asians, that you won't be impacted, and that's really not accurate. The consequences of calling it the Asian flu and the consequences of xenophobia were horrible. Just a few things: we saw hate crime, we saw an 80% decline in revenue for Asian-owned small businesses in Toronto in 2003, and closure of some Asian-owned businesses. Next slide. We saw this recently where the University of California at Berkeley, close to where I am, issued an advisory about the new coronavirus and said, if you look at the bottom one, that common reactions include xenophobia, fears about interacting with those who might be from Asia, and then guilt about these feelings. Next slide. Really unhelpful to write like this. And there was reporting in the Post and the New York Times about how this was normalizing racism and we shouldn't be speaking in these terms. Next slide. And of course, this is already panning out. We're seeing reports of xenophobia from everywhere, Sydney to Los Angeles. Next slide. And the Chinatown in San Francisco, near where I live, is very empty compared to what it usually looks like. Next slide. And the next one. And these are really important things to cover with epidemics. So I'm going to talk now really quickly about innovative stories. Next slide. One of the people that I interviewed when I was doing my research at JSA was Amy Maxman. And the next slide. And Amy is like your favorite science reporter's favorite science reporter. And she talks a lot about being a freelancer while covering Ebola in Sierra Leone, how it was risky because no company had her back. So if she got sick or hurt, like who was going to look out for her? But it was also freeing because she was really able to do some innovative reporting that would often get turned down by lots of outlets that eventually it would land. And she offered really fresh insights into the epidemic that I wasn't seeing from other reporters or other places. Next slide. So she was able to do that thanks to the help of the Pulitzer Center on Crisis Reporting, which, full disclosure, they supported me to report on Ebola and things like that too. Next slide. So this is some of Amy's reporting. It looked at just healthcare workers in Sierra Leone not being paid and therefore going on strike, and how awful that is during an epidemic and what consequences that had for Ebola spreading more widely. We can just click through the next few, just some examples of her excellent reporting. This one was totally the antithesis of the Africa is a country kind of reporting, which was, let's take a deep dive and look at Sierra Leone's capital, look at the people, they were fully fleshed out humans, it offered real detail and understanding that these are real people affected by this disease. Next slide. So I feel really passionately about reporters being protected, and I worry, next slide, that people like me who are trained to deal with epidemics know how to not end up getting infected, but often reporters are just dropped into a hot zone with a deadline and a notebook and expected to report without getting sick. Next slide. And of course, the consequences of this is just sending non-experts to cover really deadly diseases. And we did see at least one journalist get infected with Ebola while doing his job. Next slide. I am developing the Toolkit for reporters covering epidemics, a project that I started when I was a JSK fellow. Next slide. So some of the advice I got and some of the things I learned while doing my research study at JSK was that the excellent science reporters were using their scientific sources, not just to inform their reporting, but they were saying, hey, you're going to Liberia next week. What are you doing to stay safe? And what can I learn from you? What should I take with me? The issue, though, is if you wind up in the hot zone with a ton of masks and a ton of rubber gloves, but the local healthcare workers don't have that, you need to think about how that pans out ethically and what your role there is. We saw that with Ebola, that the local healthcare workers did not have the most basic resources, sometimes no running water, and then we saw journalists from the West helicopter in with like everything they needed to stay safe. And also when you are kitted up, next slide, there's an impact on how you're going to be interacting with people. So this is me not interviewing people, but I was covering Ebola and I was in a high biosafety level lab. I wouldn't want to be approaching people looking like this to do an interview, so I think we also have to think about the human element. So after the outbreak, I want to encourage us to really stay with the story and not just leave when everyone else leaves. Next slide.
Dr. Yasmin, we're going to need to move on shortly to our last few.
Yes, I'm wrapping up now. There's a lot happening in the aftermath of an epidemic that needs to be covered. And often we don't see that happening. Next slide, please. We can go through these really quickly. And then, of course, you can look at them afterwards. We need politicians and health officials to be held to account and to look at lessons learned. You can just click through the next 3 slides. They're just looking at some of the expert panels who said the World Health Organization bungled parts of the Ebola crisis and what we can learn from that. It's really important to continue that coverage after the epidemic. Next slide. There's also thinking about the stigma of infection. We can click through the next few as well, and I'll just quickly end with this, that once Ebola went away, there are still upwards of 17,000 people living with the consequences of that. This woman, Josephine Kawa, survived Ebola, and I wrote about what it was like for her having hair loss and all these other symptoms and also the stigma of infection. And we can just go through the last few slides. And what does it mean to return to everyday life? The woman pictured here is Josephine's sister, who died after Ebola had gone. She had survived Ebola herself, but did not survive pregnancy in Africa. And that's a story that we also need to continue covering on. So thank you so much for listening. Handing over to Emily.
Thank you so much. And now we're going to hear from Emily Baum.
Thank you all so much. Really thrilled to talk to you guys. So Michelle asked me to speak because I want to bring the perspective of a reporter who's covering coronavirus right now. A lot of you guys who are listening are in the same boat as I am. And so I'm really looking forward to engaging with you and talking a bit about our job at a time like this. So I'll just talk a little bit first about my philosophy for covering epidemics and infectious disease. As Michelle mentioned in the beginning, I covered Ebola in West Africa a little bit in 2016, then I also was in DRC during a yellow fever epidemic a couple years ago, doing some on-the-ground coverage of epidemics. And now coronavirus is creating an opportunity to learn how to report well from behind a desk. I know that's a situation that many of you are in right now as well. So I'd love to talk about my philosophy first. If you have been a journalist working in mainstream media in the United States for longer than the past 5 minutes, you have probably at some point been accused of generating fake news. At least that's my experience. So we've seen that with genetics, we've seen that with nutrition. And I think that infectious disease outbreaks create sort of like the golden ticket to a never-ending news cycle of fear-mongering and real fake news in the health world. I know Seema just touched on that. This is fertile soil for a tiny seed of inaccuracy on Twitter to sort of spring up into this giant beanstalk of alarmism and xenophobia and racism, right? We've seen that in just the last few weeks even. So the reason I get such a thrill from covering infectious disease outbreaks specifically is that this is sort of our big moment as health journalists to combat fake news. This is our opportunity to either empower communities with truthful data, to acknowledge what we do and what we don't know, what the experts do and don't know, as Seema mentioned. Either that, or we will turn neighbor against neighbor and actually risk sabotaging progress in this battle against this tiny invisible enemy. So it's an exciting task, and I want to talk about 3 quick rules of thumb I use to sort of pursue my work in these kinds of settings. So first of all, don't just tell people what experts know, tell the experts how they know it. So this, I think, is a good opportunity to explain processes. Michelle and I talked a little bit about this earlier this week, that there are a lot of experts who are doing their work in the middle of an outbreak, but nobody really knows how they're getting the answers that they're getting. So both of the stories you see on my screen here, one is I wrote, and the other is by my colleague Melissa Healy. Highly recommend reading her story on this front. These are both stories that were born from overhearing coworkers chatting at the coffee machine in the LA Times newsroom. We discovered quickly that many people don't know, for example, the difference between transmissibility and severity of an outbreak, as Michael was saying earlier. So we could have very quickly written a story that tells folks that the CDC believes the death rate of this is hovering between 1% and 2%. But, that leaves out vital pieces of information in the narrative. How do you calculate a case fatality ratio when you have no idea how many cases you're missing? And several other questions just like that. So in reporting this story, the one that you see on the left, I talked to folks who had done work on H1N1, and I learned a lot about the process by which mathematical modelers try to sharpen their models using something that they called the iceberg model. It's essentially a tiered model for extrapolating the quantity of various types of infections that fall below the surface of what you see in an outbreak. So that ranges from asymptomatic cases to those that result in intensive care and even death. So this is just an example of helping people understand how experts find out what they know. And I think in many ways, as reporters, we experience that social media sort of has ushered in the death of expertise. And so allowing people to have a window into professions and the people who have prepared throughout their career to help us understand these things, just giving them a window into how they do that. I think you could do the same story, just to give some story ideas. You could do the same type of story understanding how contract tracers do their jobs, how folks on vaccine development teams do their jobs, et cetera, et cetera. Melissa here on the right-hand side, recommend reading her story. She did the same with geneticists, helping combat this idea that there was nefarious activity behind this particular virus and helping show people just how geneticists have come to the conclusion of finding out what they do know about the origins. So second rule of thumb, seeking out real human beings to hold authorities accountable. Michelle did ask me to touch a little bit about my reporting from abroad, and like Seema, I did spend some time at the tail end of the Ebola outbreak on the ground, trying to follow stories that everyone else had sort of picked up and left. I think in many cases, TV crews left when the case count started falling, and there were so many humans whose lives were affected. A whole generation of orphans, people who are suffering from something called post-Ebola syndrome, where various illnesses can come as the result of the virus, even after they recover, such as blindness. So I profiled a young boy who was dealing with blindness because of the virus's persistence in his eyes. So finding real humans can really make a story compelling and can hold authorities accountable to staying present and dealing with the issue for the long term. Right now, of course, if you're behind a desk, it can feel difficult to find those real people. And I appreciated what Seema mentioned, that it's not always even necessary to be on the ground. It's possible to tell these stories when you can't get there. So if your editor's not letting you go to Wuhan right now, I encourage you, use Signal. Find people who are willing to talk to you from the outbreak. And as we see this outbreak become a larger and larger footprint in the United States in the coming days, in the coming weeks, we will have special opportunities as reporters to do this in holding officials accountable right on U.S. soil. not just federal officials, but local, regional, and state officials who are going to help combat this. Finding real people in your communities who are helping get it ready for this, who are dealing with the consequences of this, that can really help put faces to the story, no matter where you are. And I know we're short on time here. I'm going to buzz through the third tip that I have and the rule of thumb that I follow very quickly. Slowing down to answer audience's questions, even when they are not the most scintillating questions. If you're like me, you probably would like to be focusing right now on breaking big investigative accountability stories on coronavirus that you believe will forever change the way American government works. But if you take a peek at Google Trends, for example, if you've never used it, trends.google.com, excellent tool, you can quickly see what is really on people's minds, specifically people in the region of the United States that you are reporting from. Perhaps you work for a local news outlet. You can see what people are searching for. And you can also see where they may be getting inaccurate information. So all of the stories you see on the slide here are the results of finding out what questions people were really asking the LA Times as they were trying to protect their families and prepare themselves for this outbreak. So we would like to say that most Americans are refreshing the CDC website and the State Department homepage as they make their travel plans, but they aren't. And so we have a neat opportunity to kind of bring those expertise sources of information to our audiences. So when we saw masks flying off of store shelves earlier this month, we wrote that first story that you see about the importance of hand washing as opposed to just buying masks. And in fact, finding out that the sales of masks was decreasing the accessibility for healthcare workers who needed it. We also saw that there was a lot of confusion over what a novel virus is. What does that mean? We were able to do a quick explainer on that, as you can see on the screen, showing, what is the difference between doctors and epidemiologists who are learning about Ebola, where we've seen outbreaks for several years now, and something like this virus where we're learning as we go. So none of these stories on the screen are going to be submitted for Pulitzer Prizes, I can assure you of that, but these were opportunities to sort of dust off biology textbooks and talk to people like Michael, who we heard from earlier, and just inject some news you can use into the conversation, and to serve the population that is reading your news before the outbreak and then after the outbreak as well. So I have some other thoughts to share and would love to talk with all of you who are covering this, but I'm going to pause there and turn it back over to the folks at the Center for Health Journalism so that we can hear from you guys, hear some questions. Thanks.
Thank you to all of our panelists for these excellent presentations. I know that Emily has to go off to a coronavirus meeting in her newsroom, so we probably have time for maybe one or two questions specifically for Emily, and then we could move on. Does anyone have a question for Emily specifically? Right. So one question, Emily, is as we look ahead, and this seems to be kind of spinning out of control, what is as succinctly as you can, what would be the strategy that the Times has right now on the array of different stories that you're going to try and do, like even for next week?
It's a great question. I should be careful how much I say on the record here for what we have coming, but I would say this moment, it's interesting that the timing of this webinar, we've all known this was coming for a couple of weeks now, and yet today is a really interesting pivotal moment. You're starting to see the preparation and the approach in the U.S. for this kind of shifting into high gear as the first case, the first identified case of possible community spread this week. So I would say one of the main things I'm going to be pursuing is understanding how federal, implementation of rules and preparations is trickling down to the local levels. As journalists across the country, it's a really neat moment because there is not one health department in the United States, local or state, who is not involved in coronavirus at this moment. We couldn't have said that a couple weeks ago. A couple weeks ago, if you wanted to report on the US experience, you were probably focusing in Washington state, maybe in California where the quarantines were. But every state department, every state health department and every local health department is doing preparation in their communities. So I would say we're doing this at the LA Times, and I recommend everyone do this across the country, wherever you're reporting from. Look at what is happening with your unsung heroes in your local health departments and find out how information coming from Atlanta and information coming from Washington is either helping or hurting their ability to do their job in communities. I would say that's the main driver for me in the next week or two. Yeah.
And Emily, should you have time, I have two more questions. You could just answer one if that's what you have time for. One question was, which was your third rule of thumb? And the other one was about other ways to reach people in quarantined areas. And when you mentioned Signal, you were talking about Facebook Signal, which journalists can sign up to get. So maybe just talk about that and some other techniques that you might use from your desk.
Sure, I'm happy to do that. So Signal is, I recommend Signal or any other method you can find of encrypted communication. This will change depending on what environment you're reporting in, but if you are talking to individuals in China who are putting themselves in harm's way to share information, it's really important to do the best that you can to protect them in the way that you can. So any of the tips that I've gotten from doctors in China right now, families of patients in China who they believe the full story of what's going on may not be coming out of China. The first question I ask when I hear from them is, are they communicating in a way that's safe for them? And if not, asking them to adjust that so that they can speak freely. A lot of people in China who contact you will have thought this through, and they are experienced in this, but Signal is an app. I absolutely recommend downloading it. You may also be talking to people on WhatsApp, et cetera. But if your news outlet does not have a tip line, there are still ways that you can get people off of Twitter direct messages and get them to talk to you in safer ways.
Great. Thank you so much, Emily. I know you have to go. We have some other questions here for our other two speakers, and either of you can feel free to reply. One question is from Sumaira Jaja. I apologize if I'm mispronouncing your name, which is how to avoid being a racist while reporting on this outbreak. Sumaira said, we're seeing all these reports being published in developing countries, and I can see this is an issue.
Hi, Samara. This is Seema. I'll speak to that quickly. I think one thing is it's really important to cover the fact that with epidemics, we do see racist incidents happening, and we do see reporting that perpetuates racism too, and we need to call that out. I think one way of doing it, besides reporting on the fact that racism is occurring, is also having diverse sources in your stories. Every time you're writing a story, you're thinking about, well, which voices am I including and which am I excluding? And making sure the experts are diverse, and the people whose lives you're documenting and the impact on them, they're diverse too. And I think that's how we make sure that we're hearing from a range of people who are impacted.
We also have a question from Everett Smith about seeing things on social media about Lysol and its infection-fighting ingredients. Any comments on that, or just other misconceptions that people are maybe absorbing?
So there's a number of ways to clean, to sort of disinfect surfaces and things like that. And soap and water tend to be very good. You know, using soap both on your hands and on surfaces can work. And then a lot of these disinfecting agents can work. The ones that said they kill many viruses, but they're not foolproof methods. But certainly using those chemicals on surfaces can help if there's concern. And then on your hands, a lot of times, besides soap and water, using alcohol is like these alcohol gels is very important and can be useful if you're on the go, and in particular if you're in airports or trains and things like that. Using it pretty frequently is helpful to potentially protect yourself and others. So in general, those are some of the basic ways to kind of keep viruses from transmitting and spreading on surfaces.
We have a question from Bob Eisman, who asks, what is known about CDC's apparent reluctance to use faster testing methods? In other words, what's being used in South Korea?
So the testing that's being used globally is more or less most of it is the same. It's all based on the same real-time PCR type of technology. So what South Korea is doing, as well as others, they've just scaled up their ability to do real-time PCR on instrumentation, and that might have, it's not clear exactly how they scaled it up so well in South Korea, but probably it was quite literally getting a number of instruments, they're very common laboratory instruments, and this is a very common technique that's performed all over. So they were probably able to pool resources from either the public health institutions there or hospital labs and such, and really get testing up and running. So that's the same type of testing that we would be doing here in the United States. And frankly, it's not completely clear why the reagents took so long to get produced in the first place by the CDC. For example, we've recreated the CDC test kits in our own lab at Brigham and Women's Hospital. We're unfortunately not able to use it to test patients in our hospital because of the emergency health declaration and FDA restrictions, but we were able to get it up and running fairly quickly. And so I think a lot of us who are in charge of these things and studying what's going on are scratching our heads a bit, trying to understand why the CDC has really dragged their feet in a way to get these test kits out, and even at this moment in time, the testing capacity is truly inadequate.
And Dr. Mena, there's been some political conversations about the appointment of Pence as the person in charge, and that all communications will be managed centrally. How much of this is just understandable prevention of, bad messaging, or what's your take on that?
Well, I'm a physician, and I'm an epidemiologist and immunologist. So I'm not a politician, and it's hard to say exactly what the thought process is. I don't. My personal feeling is all I can give, but I don't believe that it's it was a decision made with the intention of improving accuracy in the messaging. I just don't see that as I don't see it going through Pence's desk as being sort of the arbiter of truth and accuracy. I think that the better people to really be providing the messaging and determining what's best are the public health professionals. And if Pence and the administration are involved and want to hear what's going on, I think that's great. However, I do think that public health professionals have, they understand the correct language to use, they understand how to interpret the data they're seeing and how to interpret the messages that are being presented and the research that's being performed to really understand what message to give to the public. And so I don't know that I agree with the decision to put Pence in charge, and I think the head of Health and Human Services or the head of the CDC, somebody in that capacity is probably the better individual to make those types of decisions for the country.
We have a question from somebody named Ochari Lawson who asks, how can we deal with conspiracy theories with such disease outbreaks and feelings among people that the country itself has introduced a virus?
We saw this during Ebola. We've seen it again now, as was alluded to earlier. It's not new that we see these conspiracy theories, and I think there's already been some really good reporting debunking those myths. I think it can be really helpful to use the kind of molecular proof that Dr. Mena mentioned earlier on, like saying, no, this is actually the lineage and the evolutionary history of this virus, so therefore it can't have been manufactured in a lab, for example. There is a body of evidence that says when you debunk a myth, you actually strengthen the myth and give it a platform. But there's also evidence that says it can be useful. I am much more on the side of, if a conspiracy theory is circulating, let's address it, let's dissect it, let's talk about what's inaccurate, and let's give people the honest information.
We have a question from Linda Rath, who says, Dr. Mena, is there any evidence about increased disease susceptibility or severity among people taking immunosuppressants or with autoimmune disease?
So far, there hasn't been a study that specifically addressed that question that I have seen. Now, things have moved very quickly, so possibly there has been something published at this point. But the short answer from a medical perspective is that the potential for more severe disease or for somebody to become more ill does increase for individuals in general for viral infections and bacterial infections and the like, for people who are immunosuppressed or who have autoimmune diseases. So whether individuals are more susceptible to acquiring the virus, I don't know that that would be the case, but how well their body is able to fight off the virus, individuals with those types of underlying medical problems will be potentially at greater risk of having the virus become more virulent or cause more problems for their health, yes.
We have a question from Yu Yang who says, are there any concerted measurements, any concerted measures from the scientific community and journalists to label misinformation and prevent its harm? And I'll just say, I know that there's some efforts going on, for example, I think at Santa Clara University is trying to develop a kind of medallion that could go next to a name on social media to indicate they're trusted, but I'm not sure how far along any of that is. Dr. Yasmin, do you have any thoughts on that question?
This is what I study, so I know that there are different interventions being developed, nothing that's already out there. What I find really interesting is looking back to Ebola and seeing that some of the most useful stuff was the most low-tech stuff. So, for example, in West Africa, there was a service where if you heard a myth, for example, eat raw onions and it will protect you from Ebola, you would text a certain number, your SMS would go, and then it would come back and say, nope, this is inaccurate. Or yes, this thing that you have heard is true. And it was fascinating to me that it was something that was pretty low tech that actually ended up being very useful on a large scale. We haven't seen anything recently, I think, that really addresses this, except for at least, I think, much more acknowledgement from organizations like WHO that it's not enough to just fight the spread of a virus. You have to fight the spread of misinformation and disinformation as well. And I think the medical community has ignored that for too long. We're starting to see some movement in the right direction.
And we have a couple of questions about travel. asking about what are the correct protocols for airports and train stations to hold authorities accountable, and a question at more consumer angle of how to travel more safely and how much more dangerous is it to travel than to stay home.
Well, I can't say that I would know the answer to what are the right protocols for to hold airports and travel centers like that accountable. I think that in that sense, that's an area where there needs to be, that's one example of why we really need to increase the amount of funding, and Congress needs to appropriate an appropriate amount of funding to actually mitigate this epidemic or pandemic, to at least slow the spread once it starts occurring in the states. And that's just one of these things that money needs to be really, when we're thinking about where the funding should go and what kind of money there needs to be, we need to be thinking not just about healthcare facilities, but also about airports and how to sanitize them, and train stations, and all of these things need to be really considered in depth when we're considering how to slow down the spread of this virus. In terms of individuals, I think at this point, one of my recommendations would be if you have totally non-essential travel, like going on vacation, I think it's getting to a point in time where we might want to consider reducing our non-essential travel. In particular, if it's bringing us through very congested airports. We don't necessarily know that there's any ongoing transmission in the United States, but we also don't have a good reason to believe that it's not happening at some low level, and really highly dense places like airports and cities can ultimately be some areas where the risk is the greatest, in particular because of international travel as well. And then, of course, just really being mindful. I've gotten some questions about, how do I protect my children and babies, and while traveling. And I think it's very important to just be extremely mindful about when you're touching things. What are you touching? It's very common for us to not even realize we're touching handrails and banisters, and to try to keep washing our hands and keeping distance, as strange as it might sound, but to kind of try to keep distance from individuals when they're coughing and in lines and things along those sorts. They're not ideal solutions, I know, but these are some of the common measures we can all take.
So a couple more questions quickly here. One from Samar Ashraf, who says, currently there are more than 80 clinical trials launched to test coronavirus treatments, and which ones do you see as the most promising?
Well, some of them are similar to each other, but there have been a few trials. For example, some protease inhibitor trials have been ongoing, and they seem to hold some promise in terms of actually being able to decrease the impact of this virus. Remdesivir, I think, is one of the major sort of trialed drugs right now that is ongoing and actually being sponsored by the National Institutes of Health in conjunction with the University of Nebraska Medical Center. And I think that some of the data that has come out of China so far did show some promising results. There was also some promising results following MERS and SARS for this drug, and those were even in some animal studies. So I think that if I were to put my bet on what one might be the first to be approved and get through trials, I would say remdesivir would be where I would be looking and trying to improve sort of speed up the trials to see how well they're working.
So just quickly, I know we are really a bit over. Two more questions. One from Susan Spencer. There's a lot of talk on social media of whether large gatherings in the U.S. will be canceled, such as the Boston Marathon, because of the risk of spreading the virus. Is there sufficient evidence to support such actions?
I think it's getting there, yes. Certainly, these are the conversations that need to be happening right now. Uh, and I think in the public health world, it's oftentimes best to take an approach that's something along the lines of expect the worst and hope for the best. And when it comes to canceling these large events, I think that it's at the very least time to start considering it as options and potential necessities if this virus becomes widespread and we start to see transmission occurring very quickly in multiple cities. I think there's going to be reason to potentially be canceling these.
We'll give the final question to Jonathan Bilancieri, who says that there's really a wide range in different countries and their preparedness when it comes to global health. And for countries that have very little infrastructure or dealing with civil war and other problems, are we facing really a catastrophic version of this epidemic in poorer countries?
I think it's a major concern at the moment that poorer countries and countries with less and fewer resources may be hit harder. And this extends from everything from reduced ability to potentially contain the virus, oftentimes higher density urban centers with potentially lower sanitation and hygiene practices in general. And so those can all cause a virus to spread potentially more quickly. But then healthcare resources will become more and more limiting the fewer resources that a country has. And for example, we saw in China, which has a tremendous amount of resources, they were very quickly able to build new hospitals. And that's for social reasons and financial reasons they were able to do that. Other countries will not have the luxury of being able to build new hospitals and will likely more quickly run out of ICU beds and hospital beds, for example. And so I think this is a really important consideration, and one that I know many global institutions, including the World Health Organization and funders like Gates Foundation, are taking very seriously and trying to figure out what are the best approaches to helping countries with fewer resources than countries like the United States.
With that, we're going to end our webinar. I want to thank our three wonderful speakers, Emily Baumgartner, Dr. Mena, Dr. Yasmin, and especially thank Dr. Yasmin and Dr. Mena for staying a little longer to answer all these questions. I know we could keep going. This is such an important topic. And I want to thank you, our audience, for all these excellent questions. We'll be posting the webinar a little later today, and also the slides from all of our presenters. And you will be receiving a survey that asks you for your feedback on this webinar and your greatest interest for future ones. Thank you all so much, and have a wonderful day.
Thanks.